Hello, and welcome to a very special segment of the Smile Now podcast where we are doing Ask the Expert. I'm joined here with Dr. Caleb Stott, my partner here at Smile Now. Dr. Stott, thanks for joining me.
I'm really excited to be able to do this, and I think it's going to be really beneficial for people that are looking to do these treatments and looking to somebody that can help them out.
The question is, has anyone had failed implants due to bone loss? I am slowly losing my teeth due to bone loss and have had 2 consultations so far for implants. The second consultation wasn't as in-depth as it was free. They said with a full consultation, they'll do a bone scan before confirming whether or not I can have implants. The first clinic I went to did not do a bone scan. I need to make sure if I decide to go ahead with implants, they will not fail due to my bone loss. I have had periodontal surgery in the past, and despite maintaining good oral hygiene, my bone is still deteriorating. My regular dentist believes that is it a combination of genetics and my uneven bite causing the bone loss. So a lot of things going on here, and I kind of want to address them a little bit separately, almost as if they were separate questions entirely. So one thing that really jumps out at me is that they received a consultation without having a bone scan. So we don't really call things bone scan. We usually say CBCT. So it's like a 3D X-ray. It's not just like a single plane. It creates a 3D model of the skull for us so we can move it around and see where all your bone is and things like that. And really, if you're going in for an implant consult, that should be a part of it no matter what. It's so important and so necessary for us to properly diagnose and plan your case that we've made it a free part of all of our consultations. So you don't pay for consultations when you come into our office, and everything starts with either some pictures or the CBCT before you even sit down, right? So we sit down with all this information already at hand, and that's how we're making a decision about what's going to be appropriate for you. I don't really see how that could be possible without having a bone scan. I mean, maybe you can do it, but to really give you a full definitive answer as to whether or not you're eligible for this kind of thing, that should just be a part of it. And, CBCTs, they used to be super expensive, and dentists used to really make a big deal about getting one done. But nowadays, they're super safe. It's very limited radiation. You don't really have to worry about getting multiple CBCTs in a year. And it's actually pretty similar of like getting on a flight from like New York to LA, I think is like a similar amount of radiation, believe it or not. And so get the CBCT. Your dentist should be giving you that. They should be looking at that, looking through it with you in order to give you an idea of whether or not you're a candidate. Now, as for the second part, the question is about whether or not you can have failing implants due to bone loss. So as with a lot of things, the answer is yes and no, and it depends, right? But let me kind of detail a little bit about what really goes on there. So this person mentions that they've had periodontal surgery, which means that more than likely they have periodontal disease. So they've had bone loss, right? What is periodontal disease? So I'm going to make it really simple. The word actually means around teeth. Perio means around, dont means teeth. So there is inflammation, periodontitis, itis meaning inflammation, around the teeth. And that's being caused by a particular strain of bacteria, which has a lot to do with our genetics and our specific mouth environment, that's causing inflammation around the teeth. And the body's response to that inflammation that's happening literally all the time is to run away from it. So the bone degrades around the teeth and slowly recedes over time. This can happen over periods of decades. In more acute cases, it can happen over a period of just, so many years. And someone has loose teeth that are now falling out as soon as like in their late 20s or 30s. Sometimes it can happen that way. It doesn't hurt. It's just a low-grade inflammation. Now, in a patient like that, if I just take out one tooth and I try to replace that tooth with an implant, that implant's not going to do great. If we have active periodontal disease, that inflammation is going on all around the implant and it's not going to be looking too good. However, when we're talking about in the context of a full mouth and we're taking out all those teeth that the bacteria are inhabiting and making all that inflammation and causing all that bone loss, if we can take that out, get down to the good, healthy, unaffected bone, and then put implants in, it's the closest thing to curing that disease as we can possibly get, and what we find all the time. This is probably about half the patients we treat are doing this because of periodontal disease. Their rate of bone loss after getting treated is actually very similar to people who never really had periodontal disease in the first place, because we got to that good, healthy bone, we took away the source of inflammation, and we've created a more low inflammation environment. We have healthy implants, and that bone can be preserved over time. But that's why when we see a mouth full of that bone loss and full of that periodontal disease that's still active, we're saying, hey, look, this is not something where we can take a half measure because it's going to cost you twice as much. You're going to get things redone. We need to take the teeth out. We need to get implants. We need to replace all the teeth all at one time in order to be successful.
Yeah, perfect. You really went over a lot there. That was a really good question.
Yeah.
It actually reminded me too that when I was in dental school in 2012, right? When we wanted to do a CBCT, it was literally a chair that you strapped your head into.
It's an act of Congress, and yeah.
And we were like, oh, we got to go down to the electric chair, to get these. But way different today. And we kind of alluded to this. Technology has made it so much easier to get treatments like this today, and that's brought down cost a lot.
Yeah.
And so huge benefit, but you really went over everything. With one thing I would just add is it's an inflammatory process. Like periodontitis is an inflammatory process. It's like an autoimmune disease almost in a
Yeah.
way,
Yeah.
where your body is attacking your bone cells, and your macrophages in your blood that are sent to eat and consume bad bacteria are also consuming and killing off your own
Yeah.
bone. So this is the process of doing it. And yeah, sometimes it doesn't hurt, but guess what? Those 3-month cleanings, they can be very
That does
sensitive.
hurt. Yeah.
And
You bet.
so
Yeah.
we've got a lot of people that, like you said, are in their 30s and 40s, and they have this. It was passed on familially, it's like almost part of their genetics. And this is one of the solutions. Is you can move past this. You don't have to be somebody in perio maintenance for the rest of your life.
Yeah.
And it's a decision, and there's a balance to the decision. But there are solutions for you today that did not exist, 20 years ago, I would say.
Yeah. Well said.
Does food taste different with dental implants?
Mm.
This one came from somebody with a picture of their cat as their moniker or whatever, which is awesome.
That's great.
Anyway, this is great. Super important. I would say that if you don't do implants, food doesn't taste normal, right? Because the alternative is to do something like dentures. And if you have dentures, then typically what you have is a palate on the upper denture. And typically to keep it to stay in, you're putting glue inside of it and then sticking it up against it. Well, you have tons of taste buds on the roof of your mouth. And so all of a sudden you are blocking or putting like an acrylic wall between you and your food and the taste buds that need to have that sensation. And so not doing implants makes food taste way different. Yeah. What implants does is it eliminates that. And so all your taste buds are free to enjoy and savor and ruminate on the deliciousness that is food that empowers our lives.
Yeah. Yeah. No, I think that's really good. The only nuance I would add is sometimes you can get implants and you still have dentures, right? So there are things called snap-in dentures. We do these in select situations, not quite as much as a lot of other full arch centers might. For one reason, we don't do any upper snap-ins at all. We don't really believe in that treatment because the bone quality up there is a lot weaker. You have to use shorter implants. You have to place them in a certain way for the whole snap-in thing to actually work mechanically. So it really doesn't make a whole lot of sense. We don't really see as much advantage to it as there is with getting something that's actually permanent and screwed in as opposed to snap-in. And so you can have those implants and have a snap-in denture up top, but it's still, just like Dr. Stott said, it's still going to cover the roof of your mouth. So you're still going to not feel the heat of food. You're not going to have any of those taste buds really being stimulated. And so you can have implants and it'd still be in that situation. So the only way around that is to get a permanent, fixed, hybrid, screwed in, all on 4, FP1, whatever, something that's horseshoe shaped and goes right where the teeth used to be and doesn't cover the palate. So that's super, super important to consider. So implants themselves don't necessarily get you out of the denture lifestyle. You may still have dentures that are just implant retained. They snap in, they stay in a little bit better because of that. So you're not having to use that denture adhesive. But to really get out of all the different sensations that come along with dentures, you want something that's not a denture at all. It's screwed in, it stays in all the time, it goes where the teeth used to be.
Yeah. Did you know that dental adhesive is a $2 billion market? Has a $2 billion market share.
That's insane.
And isn't it crazy?
Yeah.
That's how much people are buying glue to keep these dentures in their mouth.
Yeah. So, well, we'll make it a mission to shrink that 2 billion as fast as we can.
Yeah. Totally. That's awesome.
Okay, so this is actually a little bit more clinical in nature. So clearly this is a patient that's, had these consultations and heard something about some complications that can happen. So I like this question. So the question is, I'll reword it slightly. How often does IAN nerve damage happen after trying to place an implant? So what are they asking here? So the IAN is the inferior alveolar nerve. So this is the nerve that goes through our lower jaw, right through here. It's buried within the jawbone. And one thing that could happen, and why it's very important that we have accurate imaging before we ever place an implant, is if the screw goes too deep and it actually impinges on that nerve as it runs through the jaw, all the things that nerve serves, that being sensation to the lip right here and feeling throughout the mouth as well, and also parts of the tongue, depending on where it gets damaged, you can lose sensation because that implant is now pressing on that nerve and numbing it. Sometimes it can be a transient thing where it goes away in just a few months. Other times, if we really have a major nerve damage to it, that can actually be permanent damage unless the implant is removed very quickly and you're taking a variety of vitamin complexes and folic acid to help stimulate that nerve repair. So that can be a really serious complication. Now, what I'll say is it's a very unnecessary complication. So if the person that is treating you and giving you your implants has accurate imaging, has properly planned out the case, and knows how to identify their anatomy when they're doing the surgery, this really shouldn't ever happen. It's something that can potentially happen, and maybe you have like I said, transient temporary numbness sometimes. But an implant going directly into the nerve and damaging that, honestly, that's just going to be a result of the inexperience of the doctor or just something inadvertent that happened. That's not something that should ever, just be a part of the process by any means. Now, the question is how often it happens. More often than it should. I would say in full arch centers where people are doing this normally, it's a very rare occurrence. And, what should be happening immediately after the surgery is another CBCT should be taken so that we can see exactly where the implants we placed are in respect to the nerve. And then when we see you at your post-op, we're monitoring those sensations, making sure you recovered your sensation, you're starting to feel normal. So all of those things should be followed. And if there's any issues there, then the doctor should be right on top of fixing whatever's going on and have a plan moving forward.
Yeah, perfect. And you like you touched on right at the end, what I would say too is this does happen to some people where they do have momentary kind of numbness that they feel after we do these surgeries. That's not because the implant got close to the nerve,
right,
or it shouldn't be. It's just because as we're moving your lip and as we're identifying the nerve, because when we do these surgeries, we actually look at the nerve, like we reflect the tissue. We look at the nerve, we draw a circle around it with a surgical carbon that we have, and then that makes it so we're within a safe zone away from the nerve. We do that on every single case. So if you do have it, it should be temporary, should be short term. You mentioned the medicines that can help you out should you have it, and you should always monitor as they're improving out of it. Now, what if there is no improvement, or what if they are 100% numb? I always tell people I do tests. I do a sharp test where I poke them around and see if they can feel that sensation of sharpness. I do wispy like cotton, and I do directional stuff where they can tell me, am I moving it up or down or left and right? And they can tell me. If you're able to respond to these and know exactly what's happening, then you don't have full paresthesia or full numbness of the area. You might have 30% paresthesia, right? And in those situations, those resolve 99% of the time. But if you were 100% dead, right, could not feel anything, then that's when I would verify, where were the implants placed? Did they come in contact with the nerve? Did they cut a nerve? And if that happens, then you have to go to a specialized doctor, a microsurgeon, right? What would it be?
Microvascular. Sometimes an oral surgeon can do something about it, but a lot of times, you're getting into a pretty specialized area.
Yeah. So, and I practice in Boise. The nearest one to me that could do something like that is in Portland. So these are very specialized doctors, big metro areas, and they're ones that would actually go in like a neurologist, like a microsurgical neurologist, and they would re-sew these together to hopefully get them to regain. And I've never seen that. Personally, I've never experienced that. I've never had anyone that needs it. I have had people have some degree of paresthesia, but I've never had someone with full-on paresthesia forever afterwards. So I don't think it's super common at all.
Well said.
It is really difficult to get all the information, get really good information. And that's why I'm glad we're doing these segments for patients primarily, is to help them. And I hope that when they see this, if they have any specific questions, they just drop it down in the comments for us. If you want to send us x-rays, if you want to kind of get a second look on something, we'd be happy to put that on these segments and kind of speak to you directly if that's beneficial to you.